Okay, let's press on with our case. We have taken our history, we have examined the patient, and now we have imaged the patient. Do we need imaging if the patient presents to us without a mammogram? Yes, we do. We need to you need to see what the rest of the breast looks like. You need to see if the lesion is more extensive than it appears on clinical examination. In other words, you might find a small lump on examination, but when you do the mammogram, the whole breast is involved. You see microcalcifications all over the breast. You also need to perform ultrasound because this will tell you whether your lesion is cystic or solid. Quite benign cysts can sometimes, on palpation, feel quite suspicious. You need to know what the other breast looks like. So you need to do a mammogram and ultrasound routinely in a patient who presents to you with a lump without having done a mammogram previously. Anyway, you've gotten all of this now and you're ready to do biopsy. What biopsy method are you going to use? The traditional methods are fine needle biopsy versus a core. Now, all the fine needle biopsy will tell you is whether the patient has breast cancer or not. Is that enough information for you to make your decision? Well, not usually. At least a core biopsy is probably preferable in all cases, whether you're dealing with early or late disease. Why? Why should a core needle be more desirable? Everybody's gonna say, well, it gives you histology. Yes, but so what? It gives you histology, whereas the fine needle aspiration cytology specimen does not, you won't get that degree of detail from it. But what is the benefit of getting histology? Well, first of all, if the primary breast cancer is advanced, in which case surgery is not the primary treatment, in those cases, neoadjuvant chemotherapy and neoadjuvant hormonal therapy is the way to go. And therefore, you need at least a core to be able to get your estrogen receptors, your HER2 assay, so that you can start your neoadjuvant or primary systemic therapy. In the case of a smaller lesion, let's say you have a 3 centimeter lesion, you are contemplating breast conserving surgery or contemplating offering this patient breast conserving surgery. How does histology help here? The grade of the tumor is not a contraindication to breast conserving surgery. So it's not the grade of the tumor that is most important. What is actually most important is whether this patient has in situ disease or not. That is the crux of the importance of getting histology in a patient with early breast disease. Does the patient have in situ disease? Does the patient have in situ disease against a background of infiltrating duct carcinoma? And how extensive is the in situ disease? What is the importance of this? In situ disease, either pure in situ disease or extensive in situ disease against a background of infiltrating duct carcinoma, a condition which we refer to as extensive intraductal component or extensive intraductal carcinoma, is an indicator that the cancer is either multifocal or diffuse. Let me repeat that. The presence of significant in situ disease in a biopsy specimen indicates that the disease is likely to be either multifocal or extensive, that is diffuse, in which case breast conserving surgery should be engaged in cautiously. In fact, if you get either pure in situ disease or you get the condition which we call extensive intraductal cancer or extensive intraductal component, which is defined as a cancer in which more than 25% of the cells seen by the pathologist constitute in situ disease. If you find either of those conditions in a breast biopsy specimen in a patient in which you are contemplating breast conserving surgery, you should attempt to map that cancer either with breast MRI or with breast-specific gamma imaging. You should attempt to map the cancer with either of these modalities before you advise the patient as to whether breast conserving surgery is appropriate. Let me just refresh your memory as to the reason for this. If you find these lesions in a specimen, it suggests that the breast cancer is either multifocal or diffused, which means that the lump that you are feeling, the little 3 centimeter lump that you are feeling, is not representative of the complete extent of the cancer. I hope that that is clear. If you have a suspicious lump and your core biopsy histology comes back as normal, or the pathologist tells you that this looks like a proximity, what we call a proximity lesion, it might have some atypical changes, but you haven't quite gotten it, and it suggests that your specimen was inadequate. That is when you need to decide whether to proceed to do an incisional biopsy, meaning you take out a part of the lump, or you excise the lump completely, a so-called excisional biopsy. Sometimes the pathologist will tell you that the specimen that you sent is not sufficient to make the diagnosis. Don't bother to repeat the core. Just do an incisional biopsy if the lump, of course, if the lump is palpable, or an excisional biopsy. Just a word on biopsy of non-palpable lesions. In our setting in Jamaica, we ask the radiologist to put in a hook needle into the abnormality, the non-palpable abnormality, mammographic abnormality, and we use the hook needle to localize the suspicious part of the mammogram and remove that area. Having removed the area, let's say you had calcifications, having removed the area, you need to send it back to the radiologist, so for him to repeat the mammogram on the resected specimen to be sure that you have removed the suspicious area before you close the skin wound. In developed countries, needle localization is sort of out of fashion. What is usually done is that the lesion is localized on a stereotactic frame, and a mammotome is used to do the biopsy. Mammotome is a very ingenious instrument. It actually looks like a core biopsy needle, like the traditional core biopsy needle, but it has a channel, a hollow channel in the shaft of the mammotome, which allows the specimen, the collected specimen, to be vacuumed into a device. The beauty of the mammotome is that you do not have to repass it each time you do a biopsy. So you localize this lesion on the stereotactic frame, you pass the mammotome needle device into the suspicious abnormality, and you can take several biopsies without pulling back the needle. You take a biopsy, you suck it out, you empty the channel. You biopsy again without taking out the needle, you suck it out, and you can do several passes without having to remove and repass the mammotome. If you did this with a core needle biopsy, you'd have to repeat the whole process of localizing the thing and repassing the needle every single time you repass a specimen. It is not practical. The mammotome has solved that problem. So, we now have our diagnosis. How do we proceed to treat the patient? Well, the general principles of treatment actually depend on the stage of the disease. So we have to stage the disease first before we decide how we are going to approach it. What staging system do we use? Everybody should be familiar with TNM, with the TNM classification. But TNM is a rather cumbersome classification. It is scientific, it standardizes the whole process, but it is a very cumbersome system to walk around within your head. The American Joint Committee on Cancer Staging System, AJCC staging system, is a more facile system to use for the clinic, for day-to-day clinical application. Note that I did not say the Manchester classification. Manchester classification is not used anymore, no longer used, and it has subtle differences from the, and not so subtle differences from the AJCC system. In general, the AJCC system can be matched to the TNM system. And there is a nice little table in my PowerPoint presentation, which is available to everybody, which shows you what AJCC stage represents what TNM stage. However, in general, you should have an idea of what each stage represents. Stage 0 in AJCC means carcinoma in situ. No nodes, no metastases. Stage 1 is a tumor less than 2 centimeters, a primary less than 2 centimeters, no nodes, no metastases. Stage 2 is a tumor up to 5 centimeters with palpable axillary nodes. In general, stage 3 is more advanced than stage 2, but not stage 4. The reason why I define it this way is that stage 3 includes quite a few different things, and it is easier to remember it as being sandwiched between stage 2 and stage 4. Stage 4 is quite simply presence of metastases, and that includes supraclavicular lymph nodes. So if it's not stage 2, which is well defined, nor stage 4, it is stage 3. So pure d'orange without metastases would be stage 3. Skin infiltration without metastases would be stage 3. Tumors larger than 5 centimeters with or without axillary lymph nodes should be stage 3. Actually, without lymph nodes, the AJCC does in fact put that group into stage 2. But in general, tumors larger than 5 centimeters, certainly if there are lymph nodes, would be regarded as stage 3. Anything which is beyond stage 2 but not stage 4 is stage 3. The general approach to treatment is that for stages 1 and 2, which is called early breast cancer, we perform surgery as the first treatment modality, and this is followed by adjuvant therapy with chemotherapeutic agents, with hormones, etc. For stages 3 and 4, it's the other way around. We start the treatment course with what we call primary systemic therapy or neoadjuvant treatment, followed by a reassessment and a decision as to whether surgery is appropriate. So let me go over that again. Stages 1 and 2, early breast cancer, usually treated by surgery first, followed by adjuvant. Stages 3 and 4, usually treated first by neoadjuvant or primary systemic therapy, followed by a determination as to whether surgery is appropriate. Let me hasten to add that there is a trend towards giving everybody a trial of neoadjuvant therapy. And the reason for this is that neoadjuvant therapy is an excellent way to determine the sensitivity of the tumor to the chemotherapeutic agents that we use. So when you do adjuvant therapy with chemotherapeutic agents, you're literally shooting in the dark. You really don't know. You know, there's a probability that the tumor might respond, but you have no objective evidence, at least at this stage, that the tumor is going to respond. If you administer these agents in the neoadjuvant setting and you get a pathological response, meaning the tumor shrinks, sometimes they disappear, then you know that you have the right choice of drugs. And that is why there is a trend now to at least start chemotherapy preoperatively, even for small lesions. And then once you have assessed the response, to proceed with surgery and then continue the chemotherapeutic treatment postoperatively. So how is surgery managed in these patients? For convenience, you should divide your surgical approach into two components. The first component involves management of the primary tumor in the breast. And the second component involves management of the axillary lymph nodes. So let's deal with the first component first. What are your options? Your options are either breast conserving surgery or lumpectomy and mastectomy. Who qualifies for breast conserving surgery? Patients who have a tumor, in general, patients who have a tumor less than 5 centimeters or have large breasts but a bigger tumor. So if the patient has a high breast to lump ratio, they might still be able to get breast conserving surgery even if the tumor is greater than 5 centimeters. What are the contraindications to breast conserving surgery? There really are no absolute contraindications apart from size. As long as you can get, theoretically, as long as you can get tumor-free margins, cancer-free margins, and preferably a margin of at least a centimeter. As long as you can get that, it is allowable. But you should be cautious if, one, the patient is under 40 years old, and two, remember our previous discussion, two, if the biopsy specimen has in situ disease or extensive intraductal component. Remember that in situ disease and extensive intraductal component suggests that the disease is either multifocal or diffuse, and therefore it is unlikely that you will be able to get a margin-free resection. So those are relative contraindications. How do you decide which one to offer the patient, mastectomy versus breast conserving surgery? It is not your decision, it is the patient's decision, and therefore it is your duty to point out in an unbiased fashion what the advantages and the disadvantages of each approach are. So let's look at that. What are the advantages of breast conserving surgery versus mastectomy? Survival. There's no evidence that long-term survival is different for mastectomy versus breast conserving surgery. If it were, we would not be able to offer breast conserving surgery. So reassure the patient that whatever decision they make, the outcome by way of survival is the same. Local recurrence is higher in patients who have had breast conserving surgery than patients who have had mastectomy. And it is especially high in patients who are under 40 years old. And you need to point this out to the patient. Some surgeons have trivialized the importance of the higher local recurrence rate, since survival is not affected. However, don't underestimate the devastating effect that a local recurrence can have on the individual patient. So the patient has to determine whether they are willing to live with this higher local recurrence rate. Cosmesis is of course better after breast conserving surgery, but remember that the breast can be reconstructed after mastectomy, so this is no longer a major issue. And finally, all patients who have had breast conserving surgery need radiotherapy, whereas only 50% of patients who have had mastectomy need to have radiotherapy. This is a big one that is often overlooked. Radiotherapy is delivered in small doses over a period of a month. This can be very, very inconvenient for the patient, and therefore if there is a chance that they will, if as much as a 50% chance that they will not need radiotherapy, this may be a big plus for the patient to determine, to make a decision in favor of mastectomy. Remember also that radiotherapy has its own complications, which can be quite severe. The most important complication of radiotherapy for women with breast cancer is its effect on the vessels of the heart. And studies done in the past have shown that patients who have radiotherapy to the breast, when compared to a comparable group, stage for stage, who did not receive radiotherapy to the breast, that the ones who had radiotherapy to the breast in fact died at a higher rate than the ones who didn't have radiotherapy, but they weren't dying from breast cancer, they were dying from heart disease. So this is a big, big one. Admittedly, spillage of radiotherapy waves onto the cardiac vessels depends on your source, depends on the radiotherapy source that you're using, and you need to take this into consideration. If you are using a cobalt source which cannot be focused, the effect on the heart is potentially quite serious. However, if you're using modern conformal radiotherapy or intensity modulated radiotherapy, which are modalities which allow better focusing of the radiotherapy waves, the effect on the heart can be minimized. Having told the patient what the advantages and disadvantages are, then you leave the decision to them. So the next component of our surgical management will be management of the axilla. It is now generally agreed that if the patient qualifies for a sentinel node biopsy, that is the procedure that should be done. The purpose of a sentinel node biopsy is to determine which patients do not need an axillary lymph node dissection. I think this is the way that you should view sentinel node biopsy and not the other way around. It is not that we are trying to find out who has metastases to the lymph nodes and therefore who needs axillary lymph node dissection. That's not what we're trying to find out. Remember that we're coming from a position where everybody had axillary lymph node dissection. What we are doing with a sentinel node biopsy is to find out who does not have axillary lymph node mets and therefore those who do not require axillary lymph node dissection. Axillary lymph node dissection is of no benefit to patients who do not have metastatic lymph nodes in the armpit. Not only that, it causes most of the morbidity associated with breast operations is due to the axillary dissection, not to the mastectomy or the partial mastectomy. Most of the morbidity is due to the axillary dissection. The lymphatics are extensively disrupted, and the nerves, the cutaneous nerves, are disrupted. So the patients end up, a significant number of patients end up with lymphedema, which has its own, causes its own problems and severely affects quality of life. And the nerve disruption causes a variety of pain syndromes, which are quite annoying and which also affect quality of life. So if you can avoid axillary lymph node dissection, you should. Remember what the sentinel node is. The sentinel node is the first node in the armpit, which collects all the lymph draining from the breast and then distributes it to the second level or second tier of nodes. So that if you have any metastases, they have to pass through the sentinel node first before being distributed to the second tier or second echelon nodes. The sentinel node is usually one or two nodes which are present at Berg's level 1 in the vast majority of patients. Vast majority of patients. Occasionally, the sentinel nodes are present at level 2, but they almost never are found at level 3. And of course, we all know what Berg's levels are. The levels are determined by the location of the nodes in relation to the pectoralis minor. Those below inferolateral to the pectoralis minor, to the lower border of the pectoralis minor, are level 1. Those behind pectoralis minor are level 2, and those above the upper border of pectoralis minor are level 3. How do we locate the sentinel node? What we do at Cornwall Regional Hospital is to inject methylene blue dye. Usually it's injected in the infraareolar part of the breast, which means this is the most productive area. Remember that the sentinel node drains all the lymph from the breast, so that the dye doesn't have to be coming from the peritumoral area. It can come from anywhere in the breast. And it has been shown that if the dye is injected in the subareolar area, it is most productive of an identifiable sentinel node. So we inject our methylene blue in the subareolar area, 3 to 5 cc's, and then about 10 minutes later, we explore the axilla, and the sentinel node will show up as a nice, easily identified blue node, and we send that off to the pathologist without any preservative. No formalin is put on it, and the pathologist does cytology on the specimen and tells you during the operation whether the node is involved or not. If the sentinel node is negative, that's the end of the axillary procedure. You don't need to do anything more. If it is involved, the usual procedure at this point in time is for us to proceed with the axillary lymph node dissection, in which you will seek to retrieve about 10 lymph nodes from levels 1 and levels 2. Your axillary dissection should not extend to level 3, because when you do that, you increase your risk of lymphedema without adding any benefit to the patient whatsoever. Which patients qualify for sentinel node biopsy? The important qualification is that the axillary lymph nodes must not be clinically involved. Beyond that, we are dealing with nuances which you don't need to know at an undergraduate level. The primary requirement for a sentinel node biopsy is that the lymph nodes in the armpit must be clinically uninvolved, which means that they must be non-palpable, or if they are palpable, they must be small. And some people will even go as far as to say that they should be normal on ultrasound examination as well. So that's it. The armpit must be clinically negative for the woman to qualify for sentinel node biopsy. And additionally, the tumor should be less than 5 centimeters. These are the basic principles. Beyond that, as I said, there is controversy. Why do we insist on a normal axilla? Reason is that if the armpit is clinically involved, you have a high false negative rate for sentinel node biopsy, and you want to avoid false negatives, because false negatives are going to trick you into thinking that the armpit is not involved when in fact it is. Why do you get more false negatives in an involved axilla? Because if the sentinel node is chock full of tumor, it can't take up the dye, the blue dye. So the dye bypasses the sentinel node. The dye runs along the marginal sinus of the lymph node and then moves to another second level node, which might very well be normal, which has not yet taken up any metastatic disease. So it gets fixed within a normal node, which is in fact not the sentinel node, but that is the blue node that you are going to see when you do the sentinel node biopsy. You send that off to the pathologist says it's negative, you've been tricked. You have a false negative, and you're gonna leave a patient now with an involved axilla. So sentinel node biopsy should be avoided in patients who have a clinically involved axilla. The other modality, which is not used in developing countries, is of a radioactive colloid. And a gamma camera is used to pick up the point of greatest radiation, and therefore the sentinel node. This is not more accurate. It complements the blue dye technique, but it is not in fact more accurate than the blue dye technique by itself. But in most developed countries now, what they do is to combine the blue dye technique as well as the radioactive colloid technique. So we have completed our surgical procedure. We send off the specimen, of course, for histology, routinely for histology, estrogen and progesterone receptor assay, and HER2 overexpression assay.